Have you ever wondered why that spicy burrito from yesterday might have had you running to your bathroom? Well, it's not just about the spice, it's about a common condition we're all too familiar with: diarrhea. Hello, everyone. We are the members of Group 11. Let's see what diarrhea is.
Diarrhea is the passage of abnormally liquid or unformed stools with high frequency. The stool weight is greater than 200 grams per day.
Let's start with the types of diarrhea.
It is classified into acute, persistent, and chronic diarrhea.
Acute diarrhea lasts for less than 2 weeks, persistent diarrhea lasts from 2 to 4 weeks, and chronic diarrhea lasts for more than 4 weeks. Usually, acute diarrhea lasts only less than 2 weeks. It is a common problem encountered by family physicians. More than 90% of cases of acute diarrhea are caused by infectious agents. These cases are often accompanied by vomiting, fever, and abdominal pain. The remaining 10% or so are caused by medications, toxic ingestion, ischemia, food indiscretions, and other conditions. Infectious diarrhea is acquired by fecal-oral transmission, contaminated food and water with pathogens from human or animal feces.
Disturbances of flora by antibiotics can lead to diarrhea by reducing the digestive function or by allowing the overgrowth of pathogens, such as Clostridium difficile. In the United States, 5 high-risk groups are recognized. 1. Travelers. 2. Consumers of certain foods. 3. Immunodeficient persons. 4. Daycare attendees and their family members. 5. Institutionalized persons. Side effects from medications are probably the most common non-infectious causes of acute diarrhea. 1. Fluid and electrolyte replacement for all forms of acute diarrhea. 2. Oral sugar is given to severe diarrhea to limit dehydration. 3. Loperamide for non-febrile, non-bloody diarrhea, antimoticity, and anti-secretory agents. 4. Bismuth subsalicylate reduces travelers' diarrhea. 5. Antibiotics at certain instants reduce severity and duration. 6. Quinidone, ciprofloxacin, is given to severely ill patient with febrile dysentery. 7. Antibiotic prophylaxis for patients who are traveling.
Usually, chronic diarrhea lasts for more than 4 weeks. For chronic diarrhea, the causes are non-infectious, unlike acute diarrhea. The major causes are secretory, osmotic, steatorial, inflammatory, dysmotile, factitial, and iatrogenic.
Secretory diarrhea are due to arrangements in fluid or electrolyte transport across the enterocolonic mucosa. These are characterized clinically by watery, large-volume fecal outputs that are painless and persist with fasting and no fecal osmotic gap. Osmotic diarrhea. It occurs when ingested, poorly absorbable, osmotically active solutes draw enough fluid into the lumen to exceed the reabsorptive capacity of the colon. Osmotic diarrhea ceases with fasting and with discontinuation of causative agent. Steatorial diarrhea. Fat malabsorption may lead to greasy, foul-smelling, difficult-to-flush diarrhea, often associated with weight loss and nutritional deficiencies due to malabsorption of amino acids and vitamins. Dysmotility diarrhea. Primary dysmotility is an unusual etiology of true diarrhea. Symptoms of stool frequency typically cease at night, alternate with periods of constipation and accompanied by abdominal pain relieved with defecation. Factitial diarrhea. This accounts for up to 15% of unexplained diarrhea referred to tertiary care centers. Hypotension and hyperkalemia are common co-presenting features, often with histories of psychiatric illness. Iatrogenic diarrhea. Cholecystectomy, ileal resection, bariatric surgery, vagotomy, and fundoplication. Inflammatory diarrhea. Accompanied by pain, fever, bleeding, and other manifestations of inflammation.
Treatment for chronic diarrhea depends on the specific etiology and may be curative, suppressive, or empirical. For many chronic conditions, diarrhea can be controlled by suppression of the underlying mechanisms.
Examples include 1. Elimination of dietary lactose for lactase deficiency or gluten for celiac sprue. 2. Use of glucocorticoids or other anti-inflammatory agents for idiopathic IBDs. 3. Bile acid sequestrants for bile acid malabsorption. PPIs for the gastric hypersecretion of gastrinomas. 5. Somatostatin analogues such as octreotide for malignant carcinoid syndrome. 6. Prostaglandin inhibitor FIRs such as indomethacin for medullary carcinoma of the thyroid and pancreatic enzyme replacement for pancreatic insufficiency. When the specific cause or mechanism of the chronic diarrhea evades diagnosis, empirical therapy may be beneficial. For those with more severe diarrhea, codeine or tincture of opium may be beneficial.